Hello, everyone, and welcome to Biohackers Lab. I'm your host, Gary Cohen, and on today's episode, I have Dr. James McCarter. Dr. McCarter is currently an adjunct professor of genetics at Washington University School of Medicine and is the senior entrepreneur in residence at Biogenerator in St. Louis. He was also the former head of research for Virta Health and a previous guest on the Biohackers Lab show for episode 44. James, thanks so much for coming on for another episode.
Excellent, Gary. I'm glad to have the opportunity to speak with you.
Yeah, so the reason I've got you on is because we're going to be discussing a recent Medium article that you shared that I thought was very interesting to read, and of course went a bit viral on Twitter. And that was where you got to share the current keto myth-busting evidence that's related to research. So we're going to be busting some keto myths today and sharing what the facts are. But before we get on to what those different ones are, could you just explain to listeners the exciting news how the ADA changed its guidelines using Virta Health evidence?
Yeah. So, one of the things is, as Virta has been working to expand its offering is that we use, as part of our intervention of continuous remote care, we combine that with nutritional recommendations that use nutritional ketosis to reverse type 2 diabetes, in our patients. But the ADA guidelines for the last, really going back years are silent on low carbohydrate and ketogenic nutrition, whereas they used to recommend a low fat diet. That's largely kind of gone by the wayside, but they still are recommending Mediterranean and plant-based diets. And so they have a cycle of reviewing the information. Every year, there's a new standard of care, and I believe every 4 years, there's a new set of nutritional recommendations. And so we knew that those committees were meeting and looking at the evidence that was coming out of new publications from not only Virta's clinical trial with Indiana University Health, but also other randomized clinical trials that have been done over the last few years, such as the work out of UCSF and a number of other meta-analyses of ketogenic nutrition and low carbohydrate nutrition trials for type 2 diabetes. And so we were excited to see that in January of 2019, when the new standards of care came out, that they, for the first time, incorporated low carbohydrate and very low carbohydrate eating patterns into the recommendations around nutrition. And then that was confirmed when the nutritional guidance came out. The consensus statement on nutrition came out in April, both of those in diabetes care. And showed basically that, citing the Virta trial and citing some of the recent meta-analyses, that there is evidence that very low carbohydrate eating patterns can lower hemoglobin A1C at the same time that people see removal of glycemic control medications. And so what they said, I'll just quote from that. They said, low carbohydrate eating patterns, especially very low carbohydrate eating patterns, so that would include ketogenic patterns, have been shown to reduce hemoglobin A1C and the need for anti-hyperglycemic medications. These eating patterns are among the most studied eating patterns for type 2 diabetes. So that was just, we were tremendously enthused to see the ADA coming around on that.
Yeah, I mean, that must be because that is a historic event for, I think, diabetics, given that option now, because it is a part of the guidelines. So it just means that more healthcare professionals now will have confidence being able to give that option to patients, I think, around the world, well, especially in the US. So.
Yeah, exactly. So, and I think, and it also includes the European Association for the Study of Diabetes made a similar statement in a joint consensus paper with ADA that came out in late 2018. So I think it applies at least to some practitioners in Europe as well. And I think that makes for patients who want to explore this dietary pattern as a way of treating their diabetes, it makes that conversation with their medical provider much more comfortable. And I think it puts the provider in a better position too, that they don't have to feel that they're giving guidance that's outside of the guidelines.
Yeah, perfect. So yeah, we're going to move on to your facts. And again, it's just good information for anyone listening to this. The the third myth here is that being on a ketogenic diet will cause low blood sugar.
Yeah, and so this is something that we also don't see. So, one of the ideas that people have is that as you enter into nutritional ketosis, it's going to drive your blood sugar down not only to normal, but actually below the normal range, and that's just not the case. The thing that we're careful of in the medical practice with Inverta is to remove, again, medications that can cause this. And so if you're having a high dose of insulin, whether you're in ketosis or not, that can predispose you to a hypoglycemic event. And then sulfonylurea drugs. Most people don't need to be on those. And in the case of the clinical trial population, we actually removed, got 100% elimination of sulfonylureas. So I can throw some brand names out there. Again, I didn't have that handy. I'll have that for you next time. But you want to kind of get off of the drugs that you no longer need that are predisposing you to these hypoglycemic events in the first place.
Yeah, and I guess anyone listening to this who is on any of these drugs.
Yeah, and so those sulfonylureas would be like glipizide and glyburide are two of the most common.
Okay. Yeah, and I guess, this is always the interesting situation where we're now seeing that you can use nutrition to try lower the amount of medications or get off chronic medications when you're a type 2 diabetic. And maybe even in these situations, it just shows if maybe you are on some of these medications that you mentioned that can have adverse side effects, that hopefully even through nutritional intervention and you're being monitored closely by a medical professional, that you'll be able to safely get off these so that you don't get into one of these event stages.
Right. Yeah. And with the sulfonylureas, there are a handful, a small percentage of people that have atypical diabetes. So it doesn't clearly classify as type 1 or type 2 that actually respond nicely to a sulfonylurea, but it's about 1% of the population. So there may be patients who are being kept on those drugs for a
Good reason. Yeah. Okay. Perfect. Yeah. So myth number 4 is that being on a ketogenic diet will deprive your brain of glucose.
Yeah, and this is one that if you just sort of do a search online and you see kind of what do folks with nutrition training kind of throw up there in terms of just things that are.
Hi everybody, Jane here. I was very, very excited to see this YouTube video, but you know how it goes, trust but verify. I think Reagan said that. So that's what I've done. I've verified the information. Okay, ADA is coming around a ketogenic diet. Yay! Do I think things are going to change overnight? Not particularly. I looked at the ADA website and it really didn't look like there were changes made yet there. But this is what's opening up the door. It's helping medical care providers to, quote, go outside of the guidelines and really help people with a ketogenic diet. It's also helping empower the patient. The studies are there. This is not like fringe element. I mean, it's documented. So hooray for that. I really like James McCarter's interview. It really comes highly recommended. What myths they dispel, whether it's a sustainable diet or not. Can it cause low blood sugar? Can it cause cardiovascular damage from bad cholesterol? And on that note, at the very end of this video, I'll do the clips where it has like a cascade effect when you have too much insulin going on in your body and how it cascades into heart disease, the bad cholesterol, all of that. And they dispel the myth. Can it cause inflammation? Can it disrupt thyroid? Can it damage your liver and kidneys? Can it cause muscle and bone loss? all uh, you know, the antithesis to a ketogenic diet, but they talk it over and they have some science behind it. And last but not least is, can it deprive your brain of glucose? And I want to get into that topic here in a little bit. Okay, I did trust but verify, and uh, Joy Kitty, a registered dietitian, writes a really good article about what the ADA studies came up with, their consensus report for 2019. And Dr. McCarter's Verta studies, I'm giving you the link to that in the show notes, if you will. And Joy Kitty. These are both remote helpers for people to change their ways. And one of the things is like, does one, or that the ADA is saying that one size does not fit everybody. It has to do with personal preferences, how to what degree are you affected by it, what are the conditions you have. An example that Dr. McCarter has um, stated in the video is like, well, say you work the night shift and you're eating out of a cafeteria, and where the remote help is, I would say, what food choices to make. So, and this gal here, Joy Kitty, also is a remote helper. There's others out there. So if you really feel stuck, that might be a good option for you. My biggest help was a glucometer, and you, like the ADA says, check your blood sugar before meals. I would say check it after meals to see how the food is affecting your glucose. This was a really good tool for a period of time. You find out what works and you go from there. It's not like a permanent stick your finger thing like with diabetes. They also get into um, it underlines several eating patterns that are effective to varying degrees for achieving different goals with potential benefits including A1C, weight loss, lower blood pressure, improved lipids, uh, and how carbohydrates affect all that. And again, at the end of the video, or at the end of this video, I'll get into, it's really a good chart of an iceberg and how one thing leads to another to another. And this article also gets into the new consensus report includes low carb eating patterns and very low carb, uh, and how it affects the prediabetes as well as type 1 and type 2, and how these diets are can be effective. So God bless all of them. Um, one thing I wanted to bring up, as far as self-help or remote help or finding, boots on the ground help, I included that clip about diabetic ketoacidosis. Now, this is not the same thing as a ketogenic diet, producing ketones. Ketones is essentially you're in a fat burning mode. Your glucose is burned off, and then you could use the fat stores. And um, on that note, the glucagon from your pancreas signals your liver to make glucose, so you're never without. Okay, what I want to differentiate and not throw caution to the wind is with diabetic ketoacidosis can be life-threatening to a type 1 diabetic. So um, do not throw caution to the wind. But on the other hand, this is not so, I'm not saying it to be scary, uh, but to differentiate the two words, and this is not applicable to type 2 diabetes. I'm sorry the chart's so tiny, but I didn't want to leave any of it out. Uh, Dr. Kitty's, or the registered dietitian, includes this in her article, and this chart comes highly recommended. And it's the different diets that were included in the consensus study, and they get into the USDA dietary guidelines for Americans, which was not included. Mediterranean diet, vegetarian or vegan. And if you go back to the video, is veganism good for diabetes? And you know, it didn't take long to dispel that myth. Uh, and that Dr. Barnard did a legitimate study for the ADA, so that's where they got that information from. So I veto that one strongly. Low fat, very low fat diets, and I'm going to dispel that rumor here in a little bit. You know, really how they got it wrong. Um, so I think we've just been misled for so long. It just seems counterintuitive, but I'll get into that here in a little bit. And then it gets into low carb, very low carb, and they had very positive results. It describes what the diet consists of. It also includes dietary approaches to hypertension. And this gets into that cascade effect, you know, high insulin leading, you know, to weight gain, uh, dyslipidemia, where your lipids are off, high cholesterol, stuff like that. And high blood pressure is in on that cascade effect. And they get into paleo. So you can look that over if you like. I left the link. And here's a quote from Joy Kitty's website. And this is, you know, the ADA consensus report for 2019. That report also indicates that for adults with type 2 diabetes not meeting their blood sugar targets, or where there is a need to lower anti-glycemic medications that lower blood sugar, that, quote, reducing overall carbohydrate intake with low or very low carbohydrate eating plans is a viable approach. From the ADA report, yay! Joy Kitty also links to another great article, and this was in regard to the consensus report of the ADA. And this is just a really good time to address, quote, fat. Uh, and Joy states here is how much carbohydrate is essential in the diet. And she's referring back to the ADA study. And that is that the body has no essential need for dietary carbohydrate. And from the consensus, you know, they start off saying how much carbohydrate do you really need, but it goes on to state they're talking about the brain's requirement for glucose. And listen up, folks, this energy requirement can be fulfilled by the body's metabolic process, including glucogenolysis, gluconeogenesis, and there is one more, ketogenesis. And here's the point of it. Your liver is receiving messaging from your pancreas. It sends glucagon gets sent to your liver, and you are making glucose through these processes to require every single need of your body. The body is so smart that it knows what to do. I want to get into a little bit of a story. You know, I was recently in the hospital, and they started me on TPN. I had been nothing by mouth for, I mean, for close to 2 weeks. So, you know, maybe on day 8 or 9 or whatever it was, I'd been really protein starved. So they began me on IV nutrition. And the registered dietitian came in, and I will describe it as old school because I asked her, why do you have so much glucose in this fluid? This is something I try to avoid. So she said, well, it's brain food. Your brain requires glucose. So, I didn't major in the minors. I knew it was short term to have this steady drip of glucose into my system. Uh, but uh, but in the meantime, too, they're having to monitor my blood sugar every 6 hours to see if it's too high, too low. That's what the registered dietitian said. Well, if you're diabetic, we just give you insulin, so I would call it old school, and this is where the medical community really needs to get uh, up to date on these things. So I mentioned it to my doctor's nurse practitioner that visit me in the hospital. I just, again, not majoring in the minors, but why are they I'm trying to avoid sugar. Look at all the sugar content in that, uh, the TPN, the IV nutrition. And she looked at the number, the percent, and she said, I wonder how many grams of sugar that is. So I think that alerted her. And maybe it was her that changed the order. I really don't know how it transformed, but it was probably the nurse practitioner. Anyway, the IV bag became smaller, and they also, in a separate, like, IV bag, it's a milky white substance that's the lipid that's feeding your body necessary fats. Well, the big bag of fluid with sugar, but it also has vitamins, protein, stuff like that, got smaller, and the fat bag got bigger, so someone was recognizing what I was saying. So God bless. Okay, first of all, approximately 60% of your brain matter consists of fats that create all the cell membranes of your body. Is that enough to give you pause or at least think twice about the benefits of a low fat diet? The body needs fat. Cholesterol is the first component to make any and every hormone of your body. And I'm going to talk a little bit about this study here. Um, I couldn't fit it all on one slide. So, okay, here's the study. Alzheimer's disease is type 3 diabetes evidence reviewed. And they are talking about your brain becoming insulin resistant, which is a major contributing factor to Alzheimer's disease. So, how much does your brain need glucose with an insulin problem, and how much does it need fat? These are burning questions. So, I'll look at it just a little more closely. Okay, this study was quite lengthy, but I wanted to do one excerpt from this that was really astonishing to me, and I'll explain why in a minute. And I'll just make a quote from it. Altogether, the data provide strong evidence that Alzheimer's disease is intrinsically a neuroendocrine disease caused by selective impairments in insulin and IGF signaling mechanism. And I'll talk about the IGF here in a minute, including deficiencies in local insulin and IGF-1. And, it talks about, the involvement with these diseases has significant inflammatory mediators, oxidative stress, DNA damage, mitochondrial dysfunction, etc. Referring to Alzheimer's disease as type 3 diabetes is justified because of fundamental molecular and biochemical abnormalities overlap with type 1 and type 2 diabetes rather than mimic the effects effects of either one. And they talk about the medical studies and the use of, you know, a nasal spray of insulin to help mediate it. And I just am going to throw it right out there that why not go, you know, if there is, go to the source of the problem. Like if you have a blood sugar issue, try to fix that. If your brain is insulin resistant, maybe it needs fat. I don't know a lot about that, but it sure makes common sense to me. And I'm not pulling this study out of thin air. Mayo Clinic, all three of their clinics in Minnesota, Florida, and Arizona are also studying this actively, and are, you know, that's what they're looking at, a genetic component and intranasal insulin. And I'm going to skip back to the IGF-1 signaling mechanism. And this runs downstream from growth hormone. You know, if you haven't listened to any other videos, I am growth hormone insufficient. I had a very low IGF-1. This is where this study gets really personal. And I do receive growth hormone treatment. And one of the symptoms was a very low IGF-1. Okay, so first of all, no wonder I have had such brain fog with the low growth hormone and low IGF-1, and no wonder I've improved, number one, getting the growth hormone treatment, and number two, improving my IGF-1 and improving my eating habits have all probably have been a great contribution to my brain functioning better. I mean, I was at my sickest just in a completely buried fog. And something I want to really point out, if any of you fibromyalgia people are listening, go back and look through my videos, and if the IGF-1 is in the title, please go back and watch it. Get your IGF-1 checked. This is an indicator if you are low growth hormone. There was study after study after study indicating that fibromyalgia patients were turning up with low IGF-1, and when they did the stim test, they were low in growth hormone. And I just am beseeching you, and to get a good endocrinologist to do a workup. I mean, this stuff is, for some of you that might get the medical help you need. Okay, I'm going to finish off talking over, that whole pyramid picture of what type 2 diabetes does to a person, the whole pyramid, the whole myriad of health complications. Thanks so much for listening.
Pretty easy to understand that everything here is really a disease of too much insulin. And this is the part that sort of logic just breaks down. Because
it's vitally important that at our medical schools we start to teach insulin resistance as the single most important medical condition across the globe. This is the disease we should be worried about. Of course we must be concerned about HIV and tuberculosis and all those other diseases, but this is the real problem. And I'm briefly going to go through it. And the answer, as we as a panel believe, and has been frequently spoken at this conference, is that these are not diseases per se, except perhaps this becomes a disease. They're conditions that are caused by an abnormal biological response to an abnormal input. And the abnormal input is the high carbohydrate diet. And we have to know where we sit on this curve, and we have to know where every patient we deal with sits on this curve. Are they carbohydrate tolerant or intolerant? And if they're tolerant, they're usually sensitive, insensitive athletes, normal body weight. But down at this end, where many of us sit, this is the problem. If you continue to eat carbohydrates, that's what's going to happen. You're going to develop type 2 diabetes. It's very simple. There's one slide shows you the whole mechanism, how it happens. That's insulin resistance. And the first problem, in my view, it's a genetic predisposition, progressively worsens with age, and a high carbohydrate diet. And Jason showed us evidence for that as we get older and we eat high carbohydrate diets, we become more insulin resistant. The key abnormality is a liver that produces too much glucose. And the next feature is that we have a reduced capacity to store and use the carbohydrates as a fuel. And as a consequence, our blood glucose and insulin levels are always high, particularly when we eat carbohydrates. And as many people have shown already, you have to convert that carbohydrate into fat in the liver and then to blood triglycerides. And a consequence is that lowers your HDL and it raises your small dense LDL cholesterol particles, which are considered toxic. And as a consequence of all that, you then develop this atherogenic dyslipidemia, which I'm going to come back to. But notice the emphasis is not on cholesterol, it's on triglycerides, HDL, and small dense LDL particles. What's really interesting, I think, in the last year or two is that the key abnormality in type 2 diabetes is dysregulation of pancreatic glucagon production, not insulin. That's going to become really interesting. And the problem in treatment of diabetes is we give insulin, and insulin can't correct that problem for reasons. And that's why Justin Fung gave this amazing lecture why insulin actually hurts the diabetic patient.